On a recent edition of Question Time, Professor Dame Donna Kinnair, the Chief Executive of the Royal College of Nursing, was asked if she believed the issue of systemic racism was a problem in the United Kingdom. She gave an unequivocal answer to the question. Yes, the UK is structurally racist due to the different health outcomes experienced by ethnic minorities. In her own words, by every single measure you can apply, the outcomes are worse for black and ethnic minority patients. Therefore, with such a claim having been made by someone from the heart of the British medical establishment, it seems like a good idea to have a look at the stats which are available to test the claim that racism is active in our health system, as well as in the outcomes that it produces. Probably the most obvious measure of health which we can use is life expectancy. For this, the data is clear. There are different outcomes for different ethnic groups. However, the data doesn't fit all that comfortably within the paradigm of racial discrimination. This is because British Asians live on average longer lives than the white majority, who in turn live longer, on average, than the black minority. Therefore, rather curiously, a structurally racist society has created a situation in which the longest lifespans are handed to the Asian minority. Another important thing to note is that in the over 60s bracket, the longevity of whites and blacks are actually fairly similar, whereas the gap between them and Asians is much more pronounced. Taking the figures for the Scottish census of 2001, white Scottish males died on average nearly 6 years younger than Scots of Indian ethnicity and 4.5 years younger than Pakistanis. Whereas if we look at the areas of the UK that have the lowest life expectancy by geography, they are often those with the highest proportion of white people. The city and surrounding areas of Glasgow are one major example, and the area with the lowest life expectancy of all in the UK is Blackpool, which has a population which is almost 97% white. Therefore, Professor Kinnair's claim that minorities are worse off by every single measure is already less than convincing. But before we look at any more statistics, it is important to highlight the nature of the claim that is being made. As is often the case with claims of structural racism, there is an ambiguity about what is actually being said. It is unclear, for example, if those who point to health as being an example of structural racism mean that the NHS itself, as well as its staff, are being systematically racist, or whether the results produced are racially determined despite the best efforts of the NHS. To address the first issue, there is no convincing reason to believe that healthcare workers are acting in a racist manner. If we consult the figures for patient satisfaction with hospital visits, then the picture is clear. No ethnic group is reporting serious concerns with the manner of their treatment. The figures for patient satisfaction with GP services are a bit more interesting, as black patients report being the happiest with their treatment, whereas Asians, despite largely still reporting positive results, say they are slightly less happy than the white majority. All of which is quite interesting when you think that this is the precise reverse of the longevity statistics, meaning we have a structurally racist system where black people report the best treatment, yet having the lowest life expectancy. It is also important to remember that over a third of senior and junior doctors working in the NHS are from a black and ethnic minority background, further weakening the credibility of the notion that the NHS is some kind of bastion for racism. The evidence for unequal or racist treatment is really too mixed for any strong conclusions to be drawn. If we take something like cancer diagnoses, white people were least likely out of all ethnic groups to get an early diagnosis, whereas white people were, however, less likely to get a late diagnosis of HIV. No doubt cultural attitudes towards sexual intercourse, which is the primary means of HIV transmission, will play a role in such figures. Therefore, if we agree that the evidence for racist treatment of patients is uncertain at best, then we can move on to the second claim being made, which is structural racism is evident through outcomes. This claim is dubious by its very nature. This is because it posits the idea that even though nobody is necessarily being intentionally racist, all differences in outcomes between groups has to be deemed to be racist by definition as it somehow shows that the structure of society is, therefore, racist. A meta-racism, if you will. One of the principal problems with this idea is that it leaves no room whatsoever for different behaviours, beliefs, or attitudes of different ethnic or cultural groups in producing these different outcomes. Difference in and of itself becomes inextricably linked to oppression and discrimination. To show how silly this idea is, let us take the statistics for self-harm and suicides. White people in the UK are more likely to self-harm, attempt suicide, or report having had suicidal thoughts than any other ethnic group. For good reason, few will then claim, as a result, that society is structurally racist against white people in this regard. Instead, we are much more likely to put these results as being down to being a matter of cultural differences. Probably the most relevant factor at play in this example would be the different levels of religiosity in different ethnic communities conditioning attitudes towards suicide. To take another specific example of health outcomes to illustrate this point, children's dental hygiene provides us with a set of results that are rather puzzling. Despite being the highest earners in the UK, the Chinese minority has the highest rates of child tooth decay, and black children are less likely to suffer from this than the white majority. What exactly causes this outcome is far from obvious, but claiming that the outcome is racist because a difference is present is as absurd as it is arbitrary. Yet we are seemingly comfortable in doing this with all other manner of health outcomes. For example, the figures for diabetes look concerning at first glance. Most minorities are experiencing it at a rate higher than the 4.3% national average for men and 3.4% for women. Though notably, black African women are less likely to develop the condition than the general population, evidence perhaps of a structural diabetes privilege in favour of African women over white women. But once we start looking at other sources of data, we quickly find other factors that help provide legitimate explanations which are surely more meaningful than simply blaming it all on structural racism. According to medical research, there is evidence to suggest that Asian populations from the Indian subcontinent are genetically more predisposed to developing the condition than other ethnicities. If we look at the data regarding adult obesity, which is linked to the development of diabetes, black adults in the UK have a rate of obesity which is 10% above the national average, whereas Chinese adults, who on average don't have high levels of diabetes, have a rate of obesity which is more than 25% below the national average. Although the data for dietary intake for different groups isn't that detailed, the government numbers for healthy eating, meaning the consumption of at least 5 portions of fruit and vegetable per day, show whites scoring about 10% higher than blacks and Asians. The statistics for exercise tell a similar story, with the white majority being more likely to be physically active than blacks or Asians, and less likely to be classed as physically inactive. Therefore, genetics and behaviour can start to contextualise the initial differences in outcome with respect to diabetes, and as such should be put on the table before we jump straight to racism as an explanatory factor. Though sadly, making such careful distinctions between different factors didn't seem to trouble Donna Kinnair. A similar set of trends can be seen when we look at mental health. Once again, different groups seem to suffer from different disorders. As has already been mentioned, white people are more likely to self-harm than minorities, as well as attempt suicide. White men have the highest rates of ADHD, whereas black women have the highest rates for their gender. Asian men are more likely to suffer from personality disorders and PTSD. Therefore, the details once again provide us with a mix of outcomes. If we look, however, at overall mental health complaints, we can see that blacks are experiencing more complaints than any other ethnic group. However, one obvious factor that surely must be relevant to this example, before we reach once again to racism as our first and only means of explanation, is that black people also top the statistics for illegal drug use as well as for drug dependency. This in turn seems as likely to be a matter of culture as anything else. If we look at the statistics for admissions to hospital due to alcohol abuse, black people are underrepresented, with whites and Indians being at the forefront. On a similar note, black people are less likely to smoke tobacco than other ethnicities. with white and mixed-raced individuals smoking the most. Therefore, it shouldn't be a surprise that different ethnic groups should have different health outcomes when they choose to abuse different substances and at different rates. The influence that culture has on such habits can be seen in the distinct rates for smoking, even among different religious groups. The importance of different attitudes and cultures towards leading a healthy lifestyle and the ultimate responsibility of individuals in this regard, rather than blaming society for inflicting different outcomes on different groups, can be illustrated by the relative ease of being able to live a healthy lifestyle in the UK. Christopher Snowdon's report for the Institute of Economic Affairs on food prices demonstrates very clearly that there is little, if any, price difference between eating a healthy diet and eating junk food. The price of partaking in most simple forms of exercise have also never been cheaper, and with the aid of social media, they have also never been easier to organise. Meaning that whatever grip the phantom force of structural racism might have over us, it is easily broken if we decide to take the radical step of taking charge of our own lives and of our health. Therefore, no matter how limited our means, access to a healthy lifestyle in the United Kingdom is open to all. In summary, the question of health and ethnicity is not in any way as simple as Professor Kinnear would have us believe. The hypothesis of institutional or systemic racism struggles to account for the data and to accommodate all of its many complexities. Though one does sadly wonder how much importance is really placed on the evidence by those who seek to make such claims about structural racism.